Hi, my name is Ashley Myer, and I'm a fourth-year medical student at Northeast Ohio Medical University in Rootstown, Ohio. The other authors on this poster are Dr. Joseph Myers and Dr. Thomas File of the Department of Infectious Disease at Summa Health, as well as Dr. Mark Brigham of the Department of Surgery and Dr. Harry Kellermeyer of the Department of Pathology. So the title of our poster is Church Choir Participation Canceled by Cryptococcal Laryngitis. So the way I'll present this poster is I'll go through and introduce cryptococcal infections. I'll talk about our case presentation, clinical course of her infection. I'll present our images, our pathological findings, and then I'll talk about our review of the literature, in which we looked at 33 cases since 2016 and talk about some risk factors we identified for cryptococcal laryngitis infections, as well as our conclusions. First off, there are two principal pathogenic members of the cryptococcal family, including Cryptococcus neoformans and Cryptococcal gaudii. So Cryptococcus neoformans is the one I'll be talking about, and it's essentially an encapsulated yeast that has an association with pigeon droppings. Many people have been exposed to Cryptococcus neoformans, but a lot of people, especially those who are immunocompetent, are asymptomatic or have subclinical pulmonary infections. The principal way that it's thought that people become infected with Cryptococcus neoformans is by inhalation of fungi particles. When people develop symptomatic cryptococcal disease, they're immunocompromised, particularly by AIDS, prolonged glucocorticoid treatment, organ transplantation, malignancy, liver disease, or sarcoidosis. They most commonly present with disseminated meningoencephalitis. There's an association, like I said before, with Cryptococcus neoformans and pigeon and chicken droppings, as well as rotting vegetation. Laryngeal Cryptococcus is relatively rare presentation of the disease. Our patient is a 75-year-old woman with a past medical history of asthma, osteoarthritis, cutaneous HSV, and breast cancer, status post-mastectomy, in remission for the past 10 years. Her medications include inhaled corticosteroids for asthma. Her chief complaint was hoarseness that was progressive over the past year and difficulty singing in her church choir, which is really, her social history was significant for being married and monogamous for the past 20 years. She has no history of animal exposure, pets, or injection drug use, or STI. She denied any fever, chills, or neurologic symptoms. Her medication list included inhaled corticosteroids for asthma. Past surgical history was positive for cholecystectomy, mastectomy due to her breast cancer history, and a hysterectomy. However, it was interesting that she did clean her home gutters by getting up on a stepladder to do so herself. Review systems-wise was only positive for a sore throat, progressive hoarseness, and tinnitus. She also had a minimally productive cough where she would occasionally cough up white sputum. Physical exam was negative except for obvious hoarseness during the patient interview. In terms of her clinical course, she was referred to infectious disease by her PCP. She had normal labs, normal metabolic panel, CBC. She's referred to the ENT, and she underwent a diagnostic strobovideolaryngoscopy. On that, they found a nodular lesion on her right true vocal cord, which was biopsied and pretty much removed with the biopsy and sent for pathologic review. After being sent to the pathologist and being stained with 3 different stains, it was found to be positive for cryptococcal laryngitis, though interestingly enough, her serum antigen cryptococcal assay was negative. The patient was treated with oral fluconazole, 400 milligrams daily for 12 weeks, and at her 6-week follow-up, her hoarseness was gone and her singing voice was improved, and she was advised to discontinue cleaning her own gutters. In terms of our images here, we have a picture of a gutter with leaves, rotting vegetation, and bird guano, like the association with Cryptococcal neoformans. We also have an endoscopic picture of a larynx showing an irregular nodular lesion, right true vocal cord, like our patient had. So in terms of our pathological findings and the staining of the biopsy, we have the GMS silver stain, which stains carbohydrates in the fungal wall. The mucocarmine stain was positive for multiple fungal organisms, and that works by staining the mucopolysaccharides in the capsule, which is one of the main virulence factors of cryptococcal neoformans. The periodic acid shift stain positive for many encapsulated cryptococcal organisms, and that works by staining the carbohydrates in the cellulose wall structure of the fungi. So on our review of the literature, we found a great review of 25 cases of cryptococcal laryngitis prior to 2016 that was published by Dongle et al. And since then, we found 8 other cases, which we included in our review, for a total of 33 cases of reported patients with cryptococcal laryngitis. It's been reported worldwide. 17 of these cases were in the US, 6 in Australia, and 10 cases in other countries. And we've listed important risk factors below, including the inhaled corticosteroids like our patient, an immunocompromised host, and high-level exposures. So 52% of the patients in the review had some exposure to inhaled corticosteroids. 21% of them were immunocompromised in some way, and 12% of them had high-level exposure to bird droppings. So 85% of them were treated with fluconazole with or without another agent, most often amphotericin B. The length of the therapy ranged from 6 weeks to 12 months, and the dosage of the fluconazole ranged from 200 to 400 milligrams per day. So our conclusions is that cryptococcal laryngitis, especially primarily a primary infection like this, is really rare, and it's most associated with inhaled corticosteroid treatment. You really have to do a biopsy to confirm the diagnosis because, especially in these otherwise immunocompetent people, the serum cryptococcal antigen is negative and non-detectable. The reviews show that oral fluconazole 200 to 400 milligrams per day for greater than 3 months appears to be the most effective treatment option for these patients. I'd like to thank Dr. Joe Myers, Dr. Thomas File, Dr. Mark Brigham, and Dr. Harry Keller-Meyer for contributing to this case, and to you, the listener, for listening to my poster presentation.